It's going to be on idiopathic inflammatory myositis. This will be the outline of the presentation. So idiopathic inflammatory myopathies are a group of autoimmune, rare, and heterogeneous muscle disorders characterized by the occurrence of proximal and symmetrical muscle weakness, which can result in impaired endurance and disability. Apart from the muscles, actually, the disease can involve other organs like the lung, the joints, cardiac system, GI can also be involved, and sometimes they may be associated with the malignancies as well as an association, or it could be a paraneoplastic phenomenon as well. And when you talk about idiopathic inflammatory myositis, there are common terminologies that you will find, and depending on the classification, the grouping may vary, but these are the important subgroups of the idiopathic inflammatory myositis. One is the dermatomyositis, the other is polymyositis, and the other is the inclusion body myositis, immune-mediated necrotizing myositis, and overlap myositis, which include anti-synthetase syndrome. And we'll see the detail on the classification system. When you see the epidemiology, polymyositis and dermatomyositis prevalence ranges from 2.9 to 34 cases per 100,000 individuals. And the peak incidence is around the 50 to 60 years, but they can occur at any age group. And females are commonly affected than males. And the other is the inclusion body myositis. It's a rare disease, which is seen in 3.3 per 100,000 population. And inclusion body myositis rarely occurs before the age of 50 years and dominantly affects male patients. And the other categories like the immune-mediated necrotizing myositis is more common in females, and it can occur at any age, and it affects 3 times more females than the male population. The overlaps myositis groups varies depending on the underlying overlapping diseases as well. But commonly females are affected dominantly, except the inclusion body myositis, which is males are dominantly affected. I'm not going to go do the details of the pathogenesis of each subcategory of the inflammatory myositis, but in general, environmental risk factors with genetic predisposition, both HLA and non-HLA associated risk factors, leads to the activation of the innate immune system, with subsequent activation of the acquired immune system leads to dysregulation of the immune system, with the subsequent development of antibodies and all the destruction of the cell. In addition to the immune dysregulation, non-immune immunological processes are also involved in the pathogenesis, like autophagy, endoplasmic stress, and mitochondrial destruction with the reactive oxygen species production leads to tissue damage and all the clinical spectrums of the disease. And the phenotype the phenotypes might also be related with the variation in the pathogenesis of the disease. And when you come to the most important thing is I think the clinical features differentiation of which is very important. So when you see the muscle involvement, muscle weakness is the most pronounced in the proximal muscle groups. And when you see the clinical course, usually the lower limbs are first affected and progress to the upper limbs. And both the flexor groups are more affected than the extensor groups. Especially in the dermatomyositis and polymyositis, usually the proximal thigh muscles are involved first, and subsequently involves the upper limb and the neck muscles. And the clinical course is usually within days to weeks duration. And in the severity varies, it's heterogeneous. Some maybe have severe manifestation with a power of 2, 1, and others may come early within 3, 4 power. And when you see the inclusion body myositis, this group of patients usually present with a chronic course, and dominantly the quadriceps muscle is the one to be affected. But in addition to unlike the other group of myositis, it can involve actually the proximal, especially the distal muscles can also be involved in inclusion body myositis, like especially the hand flexors can be involved, and it's a typical feature. And in addition, the anterior calf muscles also can be involved in the inclusion body myositis. The other is the necrotizing immune-mediated necrotizing myositis. In this group of patients, they tend to have severe manifestation with lower power recurrent like 2-1. And that is usually acute with high elevation of the CT up to 500 times. And the others, anti-synthetase syndrome, and others we'll see subsequently. And like palatal pharyngeal muscle involvement may result in a difficulty of eating and swallowing, and may cause alteration of the voice as well. This, especially palatal and pharyngeal muscle involvement, can predispose patients for recurrent aspiration pneumonia, and by definition, these are severe manifestations of the disease. Severe manifestations, and they need aggressive treatment. Breathing difficulties due to weakness of the diaphragm and thoracic muscles are possibilities, but they are, in general, they are rare. And if patient present with shortness of breath, then you have to consider possible lung involvement by interstitial lung disease has to be considered, in addition to the possibility of muscle weakness or the respiratory muscle weakness. Coming to the skin involvement, Gottron papules, Gottron's papule and heliotrope rash are pathognomic for dermatomyositis, and Gottron's papules these are pinkish to violaceous to lesions on the knuckles of the hand, and the PIP joint as well can be involved. And in addition, you may find them on the elbows and the knees as well. And they are very pathogenic for dermatomyositis. And the other is heliotrope rash, which are located on the periorbital area. And they're pinkish with edematous lesions. We'll see the picture. And if you find these are very pathognomic for dermatomyositis. But in addition, you may find them in patients without any myopathies as well. Mechanic sand is described as the scaly and hyperkeratotic ski lesions, which are located on the radial side of the index finger, and the patient can have also fissures. And these are more of seen in patients with anti-synthetase syndrome in association with anti-Jo antibody. And a variety of ski lesions can be seen in idiopathic inflammatory myositis, especially in dermatomyositis. All the ski lesions that you see in lupus can also be seen in this group of patients, ranging from generalized simple photosensitivity to severe generalized erythema or erythroderma, panniculitis, livido radicularis, non-scarring alopecia, vesiculobullous lesions, cutaneous calcinosis can also be seen in this group of patients, depending on the antibodies. So these are typical signs of the Gottron's papule and Gottron sign. If you find macular lesions, they are called Gottron sign, and if they are papules, they are called Gottron's papule. These are the typical areas, but you can find, as I said, you can find it on the elbows and the knees as well, can be seen. And this is heliotrope rash, as you can see, edematous pinkish lesions. And as you treat the patients, some of these lesions can disappear. But the scar usually stays. And these are ski lesions which are located in the anterior neck, and also in the posterior neck, which we call them shawl sign. And when the lesions are located on the lateral side of the thigh, they are called Hollister sign. And when they are located on the anterior side of the neck only, we call them V sign. This is mechanics hand, which is the hyperkeratotic scaly lesions, which are usually located on the radial side of the index finger, but they can found also in the toe, and also you may find them on the lateral side of the in middle finger as well. And fissures are also commonly seen. And these are more of typical of anti-synthetase syndrome. And the other is musculoskeletal involvement. Arthralgia and arthritis are common in myopathy, and particularly in patients with anti-synthetase syndrome, and also in overlap diseases like with RA and lupus. You may find joint involvement. It affects in the small joints of the hand and feet, similar to the RA, but it's more of especially the anti-synthetase associated arthritis is usually non-erosive, but erosive forms are also possibilities. And the other organ to be affected is the lung. The prevalence ranges from varies from 5% to 90%, depending on the diagnostic method used and the population assessed. So it includes, the spectrum includes aspiration pneumonia, interstitial lung disease, and pulmonary hypertension, and also pulmonary arterial hypertension can be seen in this group of patients. But the commonest one is the interstitial lung disease. And the common presentation in dyspnea and cough are the main presenting symptoms, and the workup includes 6-me ECOG, pulmonary function test with DLCO, chest X-ray and HRCT are very important. Usually it's basal, bilateral. The lower lung parts are the one to be affected, and the common histology pattern is the NSIP. The additional patterns include the organizing pneumonia, UIP, and diffuse alveolar damage can also be found. The other organ to be affected is the heart. Clinically significant heart involvement is rare, but subclinical involvement is common, including conduction abnormalities, arrhythmias, heart rate variability, detected on ECG, and diastolic dysfunction on echo can be seen in this group of patients. And inflammatory myocardial involvement is a possibility, but the disease is dominantly striated muscle problem, and it usually spares the cardiac and smooth muscles. And polymyositis and dermatomyositis patients have 2 to 4 times higher risk of atherosclerotic arterial disease. Both the conventional, the conventional risk factors. In addition to the conventional risk factors, is the chronic inflammatory condition and treatment in relation to the treatment. These patients are at higher risk of ischemic disease. And GI involvement, especially swallowing difficulties, are often reported in patients with polymyositis and dermatomyositis, and in particular inclusion body myositis. And as I said earlier, these are severe signs and aggressive treatment is required. The other common GI complaint is gastroesophageal reflexes, very common. And patients may have a constipation, diarrhea, and abdominal pain is a common symptoms that is seen in this group of patients. And the pathogenesis mechanism, the possible mechanisms are in relation to disturbed motility and GI tract inflammation are the possible mechanisms. The other important issue in this, especially in relation to inflammatory myositis, is idiopathic inflammatory myositis have a higher risk of malignancy. This is evidenced in dermatomyositis, as 30% of cases can have malignancy. In particular, and there are specific antibodies, we'll see it subsequently. There are specific antibodies which increase the risk of development of malignancy. And patients usually will be diagnosed with the malignancy within 3 years, or within 3 years of after the diagnosis of the inflammatory myositis. And the particular specific risk factors are main patients, older age, and dysphagia are associated with the increased risk of malignancy. And the type of cancers commonly diagnosed are lung, ovarian, breast, colon, and NHL. And thus, here the association, it could be an association or it could be also a paraneoplastic, especially lung and ovarian tumors could be a paraneoplastic phenomena. The myositis could be a paraneoplastic phenomena. And if, especially in dermatomyositis patients who are failed to respond for the conventional treatment, possibility of paraneoplastic syndrome, and working up for thorough workup for malignancy has to be made. And when you treat the malignancy, the myositis may go away. The other is the anti-synthesis. The clinical manifestation of anti-synthesis syndrome is a bit different from the others. It's characterized by the classic triad of interstitial lung disease, myositis, and arthritis, with the frequency ranging from 60 to 95% of the cases. This triad can be found in this frequency. And additionally, in addition to the ILD, myositis, and arthritis, patients can have fever, Reynolds phenomena, and mechanics, and are important manifestations of the disease. And there are the anti-synthesis RNA synthase, anti-RNA synthase antibodies are very important for as a diagnostic clue. So diagnostic workup includes muscle enzymes. CK is the most useful serum enzyme for diagnosis and assessment of in myositis, but it's not that specific for the muscle because the other sources can like cardiac and GI can also be a source of the CK. It's not specific, but it's the one that commonly used for the assessment. The other enzymes are myoglobin, LDH, ST, and LT can also be used for the assessment. And what the most important thing is that CK can be normal as in 10 to 20% of patients in the first test, especially in dermatomyositis and inclusion body myositis. So subsequent assessment is very important. The importance of CK is that it can also serve as the assessment for assessing response for treatment. So, patients after treatment drop in CK serves as one of the biochemical marker for response for treatment. The other is autoantibodies. Autoantibodies are detected in about, in general, they are detected in about 60% of patients. And they are subdivided into myocyte-associated antibodies and myocyte-specific antibodies. And the myocyte-associated antibodies they are found in patients with overlap syndrome. And the myocyte-associated antibodies include anti-Rho, La, anti-PAM scleroderma, anti-URNP, and anti-Q antibodies. And these are diseases in addition to myositis. Patients will have a secondary disease like in case of, for example, like Rolla can be found in Sjogren with myositis overlap, or in PM scleroderma, you may find scleroderma with myositis overlap. URNP found in MCTD and as part of myositis as part of MCTD, or it could be an associated SLE with myositis, and also an associated SLE with myositis overlap. And the other are myocyte-specific antibodies. These are highly selective and mutually exclusive antibodies directed against the cytoplasmic or nuclear components involved in the regulation of the key process of the cell. And these antibodies are relatively specific to myositis. And the clinical spectrum also can be dependent on the antibody type. And the amino acid RNA synthase antibodies are associated specifically with anti-synthetase syndrome. As I've said, the anti-synthetase syndrome is clinically characterized by myositis, interstitial lung disease, Reynolds phenomenon, arthritis mechanics, and fever can be seen in this group of patients. And by far the commonest antibody to be seen in these patients is the JO1, which with a frequency of 15 to 20%. And the other is the PL7 and PL12. The PL7 is associated with interstitial lung disease, interstitial lung. Recently, with the very small frequencies, now there are a number of antibodies which are directed to the RNA synthase, the amino acid RNA synthase, which are associated with anti-synthase syndrome. And the other is anti-MI2. These are antibodies associated with dermatomyositis. And this and MI2 is specifically associated with the classic skin lesions with myositis, with weakness of the back, with muscle weakness. And it's found in a frequency of 10 to 15% of patients. And the other is anti-TIF1. TIF1 is associated with as well dermatomyositis. And this patients have increased risk of malignancy. Specifically, they are at high risk of malignancy. If you find this thorough workup for possibility of malignancy has to be done. And the other is NXP2. This group of patients, clinically, they can have muscle weakness, especially they can have both proximal and distal muscle weakness can be seen in this group of patients. Additionally, they are associated with skin lesions and calcinosis. And they are also associated with increased risk of malignancy. The other is the SAA. This SAA, anti-SAA is also associated with dermatomyositis, and these patients tend to have extensive skin lesions. And the other is anti-MDA5. This also associated with dermatomyositis, and this group of patients are associated with the clinically amyopathic dermatomyositis, which dermatomyositis have three categories. One is the classic dermatomyositis, which is associated with the classic skin lesions plus muscle weakness. And the other is the hypomyopathic dermatomyositis. Hypomyopathic dermatomyositis is patients who have classic dermatomyositis skin lesions plus laboratory evidence of elevated muscle enzymes, but objectively, patients doesn't have muscle weakness. And the other is amyopathic dermatomyositis, which is associated, the MDA5 is associated with amyopathic dermatomyositis, which is patients will have a classic skin lesions of dermatomyositis like heliotrope rash, Gottron's papule, Hollister sign, Shawl sign, V signs can be seen, but patients doesn't have any either clinical or laboratory evidence of muscle involvement. So these are exclusively skin problems. It's associated with MDA5, and they tend to have severe extensive skin lesions. The other is the two anti-SRP and anti-HMG CR. These two antibodies are associated with immune-mediated necrotizing myopathy. On the immune-mediated necrotizing myopathy is associated with extensive disease, patients present with low muscle power and high elevation of muscle enzymes. And these are the two antibodies associated with necrotizing immune-mediated necrotizing myositis. And this is clustering JO1, the JO1, PL12, PL7 are associated with interstitial lung disease, and the HMGCR, by the way, is also associated with statin. And it occurs, HMGCR occurs both in statin-associated myositis, and it can be seen in patients who never have previous exposure to statins as well. But the clinical manifestation is this very severe necrotizing form of myositis. And MDA5 and MI2 can also be associated with interstitial lung disease, as I said, TIF1 and NXPD associated with cancer. SCA is associated with dominant skin prominent skin lesions. These are overlap syndromes, such as the PM scleroderma with scleroderma, QURNP as associated with SLE. So far, there's no well standardized antibody test for inclusion body myositis, but in the literature, you may find a couple of antibody tests, but none of them are specific for inclusion body myositis. So we don't have any antibody tests for inclusion body myositis and polymyositis. The other most important investigation modality is the imaging. AMG mainly it supports the diagnosis, but normal AMG doesn't rule out myositis. So a child of myositis pattern are polyphasic, short or small motor potentials, and fibrillation with positive sharp waves, increased insertional irritability, and bizarre high frequency repetitive discharges. These are the three classic signs of myositis, inflammatory myositis. If you find this, they usually found in the early active phase of the disease, but later you may find myopathic pattern, which is not, it may support you, but doesn't help you to diagnose. MG you can do subsequently as for follow-up of patients. Generally, we don't use for EMG for follow-up of patients, but if you do, what you find is the earliest EMG sign to improve is disappearance of fibrillation, and relapse also is heralded by their fibrillation reappearance. But we don't use EMG for follow-up of the patients. It's usually the first for initial diagnostic workup. The other very important investigation modality is muscle imaging. We have ultrasound and MRI. Affected muscle usually appear to be normal or have an increased size and have low echogenicity and raised perfusion in case of acute muscular involvement, and echogenicity is increased and muscle size and perfusion are reduced in chronic stage. And the other, especially MRI, is considered as a gold standard for the study of inflammatory myositis, because as it depicts well, it clearly shows the details of the anatomy and specified involved areas. And the importance of this imaging is that to localize the muscle biopsy area as well, in addition to diagnostic, but it will guide you subsequent areas for biopsy. And symmetrical muscle edema, particularly in the musculature close to the limbs, which correlate well with the disease activities in T2 weighted inmates and with stare. And T1 image show fatty atrophy with musculature reflects a chronic phase of the disease. And these are T2 image with fat suppression, which shows this the increased signal intensity, shows the active inflammatory muscles, as you can see here. Increased signal intensity in the extensive involvement. Both extensor and flexors of the thigh are involved here. And you can this is minimal involvement seen here. And this is the initial image, and after 3 months of therapy, as you can see, the signal intensity increment significantly improved after treatment. But we don't use imaging modalities as well for follow-up of patients. The other investigation modality is biopsy. One thing that I forgot is MRI. One important thing in the subtypes is that patients with inclusion body myositis have a typical quad wasting, so it's very specific for relative speaking. Quad wasting is the more suggestive of inclusion body myositis. Coming to biopsy, the cellular infiltrate of skeletal muscles are characterized by biopsy is a very important investigation modality. One is for diagnosis and also classification of the subtype of inflammatory myositis. Biopsy is very important. And generally, what you find is the infiltration of skeletal muscles is characterized by mononuclear inflammatory cells, mainly T lymphocytes and macrophages are seen, but dendritic and B lymphocytes and plasma cells can also be seen. Other typical changes of inflammatory myositis are degenerative necrotic fibers with regenerating muscle fibers. So if you find those findings, generally they will give you a clue that this is an inflammatory myositis, which can help you differentiating from the muscle dystrophies. The other subsequent findings, which can give you a clue which type of specific subgroup of myositis is that in dermatomyositis, inflammatory infiltrates mainly have a perivascular and perimysial location and are dominated by CD40 cells and macrophages. Occasionally, B cells can be found, and atrophy of perivascular distribution also specific for dermatomyositis. This is the area where you will find pathologists in dermatomyositis. This is the perimysium and perivascular area. And this is the area you will find atrophy in, especially perivascular atrophy is very specific for dermatomyositis with a specificity of greater than 90%. The other is in polymyositis, the pathologies are in the endomysium. The inflammatory infiltrates, dominantly CD8 dominant infiltrates, are seen in the endomysia and endomysial location. But CD40 cells are also can be seen in this proportion. And similarly, inclusion body myositis histologies are dominantly seen in the endomysium, which is similar to polymyositis. In addition to the CD8 dominant inflammatory infiltrate in the endomysium, in inclusion body myositis, you will find rimmed vacuoles, which are very pathognomic, and intracellular amyloid deposition can be seen, and tubulofilamentous inclusions can be seen in electron microscopy. So if you find those things, then it's diagnostic for inclusion body myositis. And actually, these findings are late findings. Earlier in the clinical course, it's very difficult to differentiate inclusion body myositis from polymyositis based on histology. But clinically, you may, as I said, it's inclusion body myositis or more chronic course, and patients have a flexor of the hand muscle involvement and anterior leg muscle involvement, and quad dominant quad involvement is seen in inclusion body myositis. The other is immune-mediated necrotizing myositis. This patient, in this group of patients, the histologic findings are dominantly on the endomysia and the perimysial area, like dermatomyositis, but they have minimal inflammatory set infiltrate, and this regeneration, necrosis and regeneration can be seen. In addition to actually, more dominantly, the pathologies are localized in the perimysium, but you can find it in the endomysial area as well, with minimal inflammatory cell infiltration, with no perivascular atrophy. Additional investigations include CBC, organ function test, metabolic workup, viral screening, inflammatory markers, and organ-specific workup depending on the symptom of the patient. For example, ILD workup, GI involvement, cardiac workup depends on the symptom of the patient. But the other investigation modalities helps you for treatment purpose as well. Coming to classification and diagnosis, there's no widely accepted classification or diagnostic criteria for inflammatory myositis, and the workup for classifications is started in 1970s, but The biggest benchmark work was done by BOHAN and Peter, which they use five categories for classification of myositis patients with the five subcategories. We'll see it. The first, which serves for long, is the relatively wider acceptance. So is found in the BOHAN and Peter classification criteria. And then after, the biggest workup was done by Griegers, which they used histologic findings for the subclassification of inclusion body myositis. During the BOHAN and Peter classification criteria, they didn't put inclusion body myositis as a separate entity. But in the Griegers work in 1995, they used histology finding to differentiate inclusion body as a separate entity. And the other biggest work was done by Taimoto. Taimoto was that they used for the first time the myosite specific antibodies for the first time. They used in 1995, and subsequently by European Neuromuscular Center, the additional categories like immune-mediated necrotizing myositis and non-specific myositis categories are introduced, and they also in 2030 they used in the absence of histology findings, they tried to use clinical presentations for differentiating inclusion body myositis. But then the most recent work was done by EULAR and ACR for classification of inflammatory myositis. And for diagnostic purpose, they used a scoring system. We'll see it subsequently. And the BOHAN and Peter classification uses 5 criteria for diagnosis. One is the proximal muscle involvement, elevation of muscle enzymes, AMG, muscle biopsy, and skin findings are the 5 categories. And if a patient have got 5 of all of them, 4 of them, in fact, they will be definitely diagnosed as polymyositis. And if they have 3 of them, they are probable. And if they have 2 of them, then they're possible polymyositis. And if they have skin findings with additional 3 of the above, then they are called dermatomyositis. And if they have 2 plus the skin findings, they are probable. And if they have 1 plus the skin findings, they are a possible dermatomyositis cases. And the subclassification they use is that they label patients as polymyositis, dermatomyositis, juvenile idiopathic myositis, and the other is overlap myositis, and the other is cancer-associated myositis. These are the 5 categories which are introduced by the BOHAN and Peter, but they don't, at this time, the inclusion body myositis was not a separate entity. And sorry, I think this is a scoring system, which is, I don't know. So this is the 2017 EULAR diagnostic criteria. They used a scoring system for the diagnosis of the inflammatory myositis. They subcategorize them with patients who have got muscle biopsy and those without muscle biopsy. In the muscle biopsy group, we give, for each clinical sign, we give a score, and in this category system, they use also antibodies. Antibodies are also given a specific category. As you see, in the BOHAN and Peter, antibodies were not introduced. And if the patients have got, in the presence of muscle biopsy, if they have got a cumulative score of greater than 8.7, then with a probability of greater than 90%, they will be diagnosed as inflammatory myositis. And in the absence of muscle biopsy, score of greater than 7 will be enough to categorize them as idiopathic inflammatory myositis. Once you diagnose them, then the subsequent classification is that patients would you label them as above once they fulfill the criteria for inflammatory myositis. If they are less than 18, then if they've got skin lesions, the typical dermatomyositis skin lesions, you label them as juvenile dermatomyositis. And if they don't have the classic findings, then you label them as juvenile myositis, juvenile myositis, or polymyositis will be the category. In those patients who have above 18 with typical skin lesions, then you classify them as with typical skin lesions, you classify them as dermatomyositis. And as I said, if the patients doesn't have any muscle weakness, then they are called amyopathic dermatomyositis. If they have any clinical, if they have laboratory evidence of elevated muscle enzymes with normal power, you call them hypomyopathic dermatomyositis. It's not incorporated as a separate entity here. And then if they don't have the classic skin lesions, then the clinical feature is the most important thing that will help you to get your, and the histology is the one that will help you guide which subtype it is. Then if the clinical manifestations are like the inclusion body myositis, the flexor of the hand involvement, dominant quadriceps muscle involvement, asymmetric muscle. Most of the non-inclusion body myositis are characterized by symmetrical muscle involvement. The inclusion body myositis can be asymmetrical involvement, quad involvement, anterior leg muscle involvement. If they have those clinical clues, then it's most likely inclusion body myositis. The other is muscle biopsy findings, as I said. Will help you which types in patients if you find vacuoles, inclusion vacuoles and amyloid deposition in the cell, then these are clues for possibility of inclusion myositis. If you don't find those things, then patients will be labeled as polymyositis. So inside the polymyositis, you'll find immune-mediated necrotizing myositis, overlap myositis, and antisynthetase syndrome also incorporated in this category. And the subclassification here will depend on the clinical feature and additional findings. For example, patient was mechanic sign, fever, Reynolds phenomena, ILD, arthritis, then obviously if they have also antibody evidence of the antigen, like anti-Jo, PL7, PL12, then obviously these patients will be labeled as antisynthetase syndrome. If they have severe muscle weakness with high elevation of high as 500 times elevation of muscle enzymes, then most likely with histology finding of regenerating and necrotic muscle with minimal inflammatory set infiltration, obviously these patients will be immune-mediated necrotizing myositis. And even without histology, if you find anti-HAMXR antibody, then obviously those antibodies will help you to diagnose the specific type of the antibody, the specific type of the inclusion body, the inflammatory myositis. So coming to the treatment, myositis treatment is not like a guideline-based kind of treatment. So because of the rareness of that disease, it's very difficult to find, large RCTs, large RCTs, this kind of diseases. But there are accumulated experiences with case serious studies and cohort studies, and we have a guiding, literature evidences to treating of this group of patients. And the first line is the glucocorticoids immunosuppressants are the backbone of the treatment. And when I say glucocorticoids, Despite the lack of controlled clinical trials, it's generally agreed that glucocorticoids are the anchor drugs for the initial myositis treatment. And the starting dose is prednisone or its equivalent of 0.75 to 1 milligram per kg per day with an average dose of 60 milligram, not exceeding 80 milligram daily. And some literature you may find as high as 100 milligram, but not exceeding 80 is what you find in most of the literature, including EULAR recommendation. And if patients have severe myositis or other prominent extramuscular complications such as ILD, pulse therapy has to be considered for 3 days, has to be considered. And how does, and then does the, so what we call it, the severe manifestations are patients who have dysphagia, patients who have ILD, and patients with a power of 2, 1 are considered as severe disease, and this group of patients needs pulse therapy. Even additionally, you may, in addition to pulse therapy, you may need triple therapy, like in addition to immunosuppressant, immunoglobulin has to be considered in this group of patients. And high dose steroids should be maintained for a minimum of 4 months, 4 weeks, minimum of 4 weeks up to maximum of 12 weeks. And subsequent tapering can be considered. And the tapering dosing is guided by the muscle power and also CK. Other investigation models are not usually used for assessment of the patients. And dose reduction is about 22 to 25% monthly until the last effective dosage. And within 6 months, you have to come down to this dose and able to taper, wean off from steroids and the immunosuppressant, the other steroid-sparing agent has to be continued. So the first line immunosuppressant steroid-sparing agent are methotrexate and azathioprine, and there's no strong RCT evidences for methotrexate, but the dosing is similar. But the retrospective study supports the use of methotrexate as a first-line therapy in myositis, and dosing is similar up to 25 milligram, similar to rheumatoid arthritis dosing. And there's no RCT evidence in adults, but the juvenile dermatomyositis, one RCT showed MTX plus prednisone is superior than prednisone alone in terms of short median time to clinical remission and prednisone discontinuation and longer time to treatment failure. The other first-line agent similar to methotrexate is azathioprine. Azathioprine is a dose of 2 to 3 milligram per kg per day is preferred by some clinicians as an initial immunosuppressive agent of choice in combination with glucocorticoids. And comparative studies have suggested that methotrexate and AZA have similar efficacy. And so AZA might be preferable in a situation like patient who have liver disease, alcoholic patients, patients with ILD. The practice is commonly methotrexate used as a first-line agent, and those patients who are failure of methotrexate or intolerant, and you consider azathioprine, but they are compiling reasons. For example, patients with myositis plus ILD, then obviously aza has come to the picture. So methotrexate and azathioprine as the first-line agent. So patients who have severe disease, those patients with a power of 2 or 1 or 0, and 1, 0 especially, to maybe consider patients who have dysphagia or alteration in voice, or patients who have interstitial lung disease, then IV immunoglobulin will also be considered as a triple therapy, initial triple therapy. And second-line agents are glucocorticoids plus MMA. Patients who have failed with methotrexate or azathioprine, or for different reasons. It could be from the treatment failure, or could be side effect issues. Then you can use MMF, tacrolimus, cyclosporin, or a combination of therapy with methotrexate and azathioprine can be considered with IV plus or minus IV immunoglobulin. The third-line agents are glucocorticoids, plus rituximab. Biologic agents come to the picture, cyclophosphamide or corticotropin injection, and all other biologic agents can be used. Investigational studies can be used as a third-line agent. So this is a flow chart for ILD management. So patients who have ILD, mild to moderate disease, depending on the lung function, oral glucocorticoid with a dose of 1 milligram per kg per day, or intravenous glucocorticoid pulse therapy has to be considered. Actually, psycho patient have to consider, especially moderate and upper, have to consider pulse therapy, and subsequent maintenance therapy can be made MMA for azathioprine. On failure as second line use, you can use tacrolimus or cyclosporine. And the patients with severe disease, intravenous glucocorticoid, additionally cyclophosphamide or rituximab has to be considered in maintenance, especially in patients whom you use the cyclophosphamide. The maintenance has to be switched either MMA for azathioprine, and failure of those, you can use tacrolimus or cyclosporine. And these are investigational. There is no strong, well, evidence that RCTs combination of rituximab and cyclophosphamide can be used in severe and refractory disease. You can consider that, or you can use anti-TCL agent CTL for a blocker, but it can be considered as well. In so far what we have seen is generally those the drugs that we have discussed so far, they non-specifically block the immune system, but the biological agents are more or less targeted therapies to specific area. So the studies, the well-studied and well-evidenced in myositis is rituximab. Rituximab is a CD20, anti-CD20 agent, which anti-BCL CD20A blocking agent. And there are RCT evidence and case series studies it's effective in patients who are refractory cases and patients especially in immune-mediated necrotizing myositis. So most of the drugs are not effective, and rituximab is one of the very promising drugs that helps this, especially immune-mediated necrotizing myositis patients, and even all other forms of myositis were fail for the MMA cyclone in the failure of cyclophosphamide, MMA, and other agents. Rituximab becomes a very effective agent. And the other studied agents are abatacept. Also, evidence shows that's very effective in this group of patients who have failure of those drugs. That's CTL for TCL co-stimulatory agent blocker, and it's also very effective. And the other agents from the biology which are well studied are anti-TNF agents. The results are the two agents which are well studied are infliximab and etanercept, and results are conflicting. And actually, in some studies, they found that these agents are associated with worsening of the myositis, and some of the studies show the improvement. And these are anti-TNF agents. So if you see the EULAR guideline, they don't recommend. I mean, when I say guidelines, their book, in the EULAR book, if you find that they actually don't recommend anti-TNF agents for myositis management. But short of the other options, you can give it a trial for anti-TNF agents. But there is a risk that the flaring of the disease, and they're not well-preferred agents. The other is tocilizumab, anti-interleukin-6 blocker. There are case series studies. Ongoing RCT, phase 3 RCT is ongoing as well on tocilizumab, and they're found to be effective in refractory cases. The others, like interleukin-17, 23 blockers, including